Okay, so it's 3 o'clock and there are some folks still joining, but I think because of the time that we have, which is only 50 minutes or less, I think it's important that we begin. So I want to welcome the participants to this session, which is focusing on drug use and opioid overdoses. And we have an amazing team of people who will be presenting today on the panel. They're Ellen Donnelly, Amity Mehta, and Jessica Xavier. And each of them has folks who will be joining them during their panel presentations. Again, thank you all for joining. And we're going to begin so everyone has enough time to share. Last but not least, anyone attending or the panelists who want to provide feedback or questions or just comments, please put them in the chat and I will be sharing information back with everyone as we move through this session. So I'm going to turn the mic over to Ellen Donnelly. Ellen, you have the floor. Thank you.
Thank you, Marcia. Marcia, we have a quick question. How do we share our PowerPoint? You're on mute.
Okay, at the bottom of your Zoom, there should be a number of items. Mute, stop video, participants, share screen.
And the host has disabled participant screen sharing.
Okay, let me figure out why. Hold on. Okay, well, I have rectified that, Ellen.
Okay, thank you.
Sure, thank you.
So thank you all for coming to our presentation this afternoon. We're broadcasting to you from the Newcastle County Division of Police. I, Ellen Donnelly, am virtually here with Captain John Treadwell to my left and Hero Health Program Coordinator Daniel Moss on my right. We're here to talk to you about the efforts and successes of the department's Addiction and Behavioral Health Unit. We want to introduce you to two of its programs and leave time to address questions that you might have. Before beginning, we want to thank the Bureau of Justice Assistance for its support of this project. Now, during this presentation, we want to convey three key takeaways. First is that non-medical use of opioids is changing the roles and responsibilities of law enforcement. Communities are increasingly facing problems of addiction that we cannot arrest our way out of. It's also becoming evident that only reacting to overdose incidences as they arise is not enough. Instead, proactive responses can be undertaken, and this leads us to our second takeaway, which is that law enforcement can be a key resource to connect people to treatment and supportive services, especially if these individuals come up with a coexisting mental health issue. And third is that teams of police officers and full-time civilians based in an agency can lead to better outcomes than if treatment or diversionary programs were absent. Now, in terms of background, you might ask, why do we choose to focus on Delaware and Newcastle County? Delaware, unfortunately, ranks among the top states across a variety of opioid metrics. For instance, as of 2018, it has the second highest age-adjusted overdose death rate, right behind West Virginia. Now, such drug poisonings are unevenly distributed across the state. They are concentrated in Newcastle County, which represents the northern part of Delaware that's highlighted in blue here. And in this section, 79% of overdose incidences occur. Now, Newcastle County Division of Police, hereafter in this presentation referred to as NCCPD, has jurisdiction over all unincorporated towns and neighborhoods outside of the small city of Wilmington, Delaware. And it too has seen a surge in fatal and non-fatal overdoses within the last 5 years. And oftentimes and regrettably, these incidences involve the same individuals and the same locations. And so these circumstances prompted a response by the agency. As an initial step, NCCPD developed the Hero Health Program in May 2016. It was modeled after the Angel Initiative in Gloucester, Massachusetts. That very program was premised on the idea that any person in the community seeking help for a substance abuse disorder could visit the police department and be referred to immediate treatment without fear of subsequent prosecution. Now, people in the Hero Health Program could enter in voluntarily, or individuals could join the program in lieu of arrest or by recommendation by an officer. Now, the program started off with NCCPD partnering with local treatment providers such that Hero Health participants would receive 60 days of treatment and counseling via treatment partners at no cost and regardless of how they joined the program. But Hero Health wanted to expand its scope, and it recognized that helping people seeking help could benefit from assistance beyond being referred to detox or treatment alone. And as a result, the program has benefited from capacity development. And let us highlight two major improvements over time. The first major improvement was the hiring of a full-time Hero Health coordinator. And this was driven by support by the University of Baltimore's Kirkley Initiative. Our coordinator, Dan Moskier, is the single point and consistent point of contact for all program participants. Simply put, the Hero Health coordinator manages all aspects of program engagement, ranging from treatment and criminal justice involvement to, more importantly, connecting individuals to supportive services, which could range from housing and employment to transportation, mental health, and other needs. This person also plays a key role in terms of outreach. For example, by making attempts to contact people who experienced an overdose and inviting their participation in the program. So unlike the Gloucester Angel Initiative, Hero Health, again, does not rely solely on volunteers. And at the end of this presentation, Dan is here to answer questions that you might have. Now, a couple of years later, the NCCPD has created an informed unit and has formulated the Addiction and Behavioral Health Unit. This was made possible due to support from the Bureau of Justice Assistance. And we can break down these activities into two sides. On the Hero Health side of the program, there's still the coordinator and affiliated officers, but there's the additions of a nurse, a clinician, and a case manager. Likewise, there is a child advocate who assists people under the age of 18 who've been impacted by overdose and addiction within their families. We'll also talk about the mental health side of the program in the following. But first, let's take a look at the Hero Health Program participants as well as the outcomes. While evaluation data is being newly collected now, an analysis was conducted between the start of the program in May 2016 and that of October 2018. And from that work, we learned quite a few things. First is that we found that the nodal participant is white, male, and about age 33. You might say, well, this pattern reflects the demographics of Newcastle County, but it also reflects shifts in opioid use. Namely, as substance abuse treatment data shows, more white, older, and suburban people are seeking help for opioid addiction today relative to, say, 1960. Importantly, we also learned about substance use patterns. About 86% of participants reported using an opioid in the last month, with nearly 3/4 stating they had used heroin during this time. Cocaine and marijuana use was also reported. So this broadly suggests, right, that addiction-related services should retain a wide and broad focus on all forms of substance use. Now, we also learned that capacity development matters. Let's take a look at outcomes that happened before and after the hiring of the Hero Health Program Coordinator. And we're going to go from left to right here. On the far left, we see detox rates completed, and we see that 56% of participants were able to complete detox before the hiring of the Hero Health Coordinator, and this increases to 77%. In the middle bars, we can see whether or not a participant accepted next level care after completing detox, and we see a 24% increase in next level care accepted following that hiring. And on the right bars, We see rates of non-compliance that have subsequently decreased. And so what this effectively means is that having full-time staff, rather than say just volunteers, which is the Gloucester model, having that staff based full-time in a law enforcement agency makes a difference in terms of our treatment outcomes. Now, not to be neglected, NCCPD has also developed a mental health unit that works closely with the Hero Health program. The MHU is developing new strategies to work with women with mental illness and individuals with coexisting mental illness and substance abuse issues. The goals of the MHU include increasing the use of supportive services related to co-occurring disorders, diverting people out of the emergency room and jail, and encouraging the initiation and engagement in treatment. Captain John Treadwell can answer some of those questions you might have about the mental health unit. Now, while both programs are less than 5 years old, so far NCCPD has learned some key lessons. The first of which is that attempts must be made to address stigma, especially that around asking for help for a substance abuse disorder and doing so by contacting law enforcement. Some promising practices involve having police officers rotate in their involvement in outreach efforts and making use of opportunities to offer privacy to program participants. For example, using unmarked vehicles for transport. Second, all of this work needs to be done by taking data-driven approaches. For both programs, NCCPD has developed extensive case management systems to monitor participants, outreach campaigns, and training. In this way, the department can offer opportunities to better assess what works and for whom. And finally, there are efforts to enhance the credibility of these programs through collaboration. NCCPD has formed close partnerships with local organizations and has also affiliated itself with national campaigns like People Empowering People and Mental Health America, formerly known as NMHA. As these efforts, will only become more successful as they are embedded in the community. Now, with that being said, we thank you for listening to our presentation. We hope that you've learned a bit more about our emerging interventions. We're going to yield our time to Q&A at this point.
Thank you very much. That was very interesting and key in relation to what's transpiring in our society. There are several comments in the chat, and I don't know if you can see those or not, but the points are: how is NCCPD prepared to acknowledge and respond to the fact that many people may have past traumatic experiences with law enforcement, which could serve as a direct barrier for engagement? And then they also talk about why are law enforcement officers involved at all? And then also, doesn't non-compliant just mean that the service isn't working for a person's needs? And I think you can see them. They're from any comments at this point?
Yeah, to that first part, one, we are prepared to acknowledge that because of past traumas, either real or imagined, people may be reluctant to deal with law enforcement. One, on the mental health side, our officers wear softer uniforms. It's not the uniform that you see me dressed in right now. We are moving to put those officers in unmarked cars. The reality is the officers there, more of a security. And if we go to somebody and we're dealing with them and they have a mental health need, even though that officer has additional mental health training, such as mental health first aid, both adult and youth, trauma-informed training, and other training to help them deal and understand those who are suffering from cognitive and or chemically induced disabilities. When they get there, their primary role is to make sure that the scene is safe, and then they turn it over to the mental health professional that is paired with them, because we have the co-responder model, and that mental health professional then takes the lead in the interaction with that person. And to your point, when we're doing outreach, a lot of times, initially, the people that we're trying to contact and assistance, they're a little bit reluctant. And then we walk them through our program, and that the police are not there to arrest you. We're trying to meet you where you are to address your needs. and make the connections to care. And once we started to do that, through both Dan's efforts and the efforts of the team, including the police officers, the reception from the public is just, it's been amazing.
Okay.
So we are aware of that. We take steps to address that.
Great. Does anyone else in your team want to add anything?
And you want to talk about the difference?
Also, I think a point, and we have about a minute or so, a point that's made is why use stigmatizing language that blames people living with substance use disorder for the failure of a treatment or support system to effectively serve them, instead of recognizing those incidents as a failure of the program to provide what people need.
So I can answer that question.
It's
First-
more, go ahead. Actually, the question's about why are you using stigmatizing language that blames people living with substance use disorder?
Okay, that term non-compliant is an internal metric that we have according to our parameters, which is adherence to an individualized care plan. At no point in the program is an individual addressed as non-compliant.
Right.
That's something that we use internally. That we are, I think one of the values of working with a research partner is that we are able to identify areas where we can strengthen and support sustained recovery. I also wanted to add one thing to the first question, if I may.
Okay, quickly.
Yes, I'm a civilian, and the officers coming in uniform have proven to be exceptionally effective when establishing trust and a connection with individuals in the community. So that, coupled with a nurse in scrubs, there's a level of credibility that is otherwise I would not be able to do as a civilian alone.
Okay, thank you very much. And maybe we'll have time later on for more conversation. Okay, so we're going to move on. And I'm excited to introduce Amity Mehta. And Amity, I'm going to turn the mic over to you now.
Hi, everyone. So I'll be sharing my slides. Hi, everyone. My name is Amity, and I work as a research coordinator in the harm reduction services at the BC Centre for Disease Control. And in this presentation, I will be discussing the awareness of the Good Samaritan Drug Overdose Act among people who use drugs in BC, Canada. So a little bit of a background on why the Good Samaritan Drug Overdose Act was enacted. So a public health emergency was declared in BC in April 2016 due to an increase in the number of opioid overdoses. And despite the introduction and scale up of many harm reduction efforts, overdoses and overdose-related deaths in BC continue to be very high. And prior evidence suggests that most overdoses occur in presence of bystanders who may delay or not call 911 at overdose events due to fear of police involvement. Therefore, to overcome this concern, in May 2017, the federal government of Canada enacted the Good Samaritan Drug Overdose Act. So the GSDOA provides legal protection from prosecution for simple possession of illicit substances. The protection includes the people who overdose, the responder, or anyone present when 911 is called. And it provides protection. However, it does not provide protection from other outstanding warrants or charges, except for that for simple possession. And although the Good Samaritan Drug Overdose Act aims to encourage the bystanders to call for assistance at the overdose events, it is unclear the degree to which the act was successful in achieving its intended outcome, and if the people who use drugs are actually aware of the Good Samaritan Drug Overdose Act and its tenets. Therefore, the BC Centre for Disease Control introduced the GSDOA evaluation project. And the main objectives of this project are to assess the knowledge, attitudes, and experiences of with regards to GSDOA amongst people who respond to experience or witness an overdose. And this slide shows the various components of the GSDOA evaluation project. However, in this presentation, I will just be covering the findings from the harm reduction client survey. It is an annual cross-sectional survey assessing the substance use trends and use of harm reduction supplies among the clients assessing harm reduction supply distribution sites in BC. And in the 2019 version of the survey, questions were added to assess the client's knowledge of the GSDOA. So the purpose of this analysis is to assess the awareness of the GSDOA among the clients of the harm reduction supply distribution sites, and the objectives of this analysis are to explore the awareness of the GSDOA, the understanding of the GSDOA, and the factors associated with the GSDOA awareness among the clients of harm reduction supply distribution sites. So a total of 621 respondents accessing the 22 harm reduction supply distribution sites in BC responded to the 2019 survey, which was administered between October 2019 till December 2019. And then we did descriptive analysis and multivariable logistic regression to assess the data. The slide shows that how the study sample for the descriptive analysis and then the bivariable and multivariable analysis were obtained. And we can see that the respondent for the descriptive analyses, we only restrained the sample size to the respondents who provided a valid response to the outcome variable, which assessed the GSDOA awareness among the respondents. And for the bivariable and the multivariable analysis, we went with the we only included the respondents who provided a valid response for the demographic or predictor variables or the outcome variable. So this slide shows the results from the descriptive analyses. And here we can see that approximately 50% of the survey respondents mentioned that they were reported that they were aware of the GSDOA. And amongst those who were aware, less than half had a complete understanding of when the GSDOA provides legal protection, and less than 2/3 had a complete understanding of to whom the GSDOA provides legal protection. If we just look at the stratification of the study variables by the GSDOA awareness, we can see that the GSDOA awareness was common among respondents who identified as men, had paid work, were 30 years of age or older, accessed services from medium or large urban areas, lived in 2 of the 5 health authorities in BC. Also, GSDOA awareness was common among respondents who had a Naloxone kit, obtained harm reduction supplies frequently, that is greater than or equal to a few times a week, witnessed an opioid overdose or experienced an opioid overdose. Also, the slide shows how the final model for the multivariable regression analysis was obtained. And initially, we did a chi-square test of independence between each of the predictor variables and the outcome variable. And all those variables that had a p-value less than 0.25 were then added to the multivariable model. And then we did a stepwise backward selection approach based on the lowest AKI information criteria, and also used conceptual relevance to get the final model. So this slide shows the results from the multivariable logistic regression. And here we can see that GSDOA awareness was higher among respondents who obtained harm reduction supplies frequently in the last 6 months, compared to those who obtained them occasionally or did not obtain them in the last 6 months. And also GSDOA awareness was common among respondents who identified as men compared to those who identified as men compared to those who identified as women or other genders. There are also some strengths and limitations associated with the study. One of the key strengths for the study is that, to our knowledge, this is the first study in Canada to quantitatively assess the awareness of the GSDOA among people who use drugs. And we have obtained a province-wide sample, and also our sample is of a fair size, and the study sample includes people who use drugs and who have used the people who use drugs, who use the substances, who use a variety of substances and use them via various modes. There are also some limitations associated with the study, as we are using a cross-sectional study design, so causality cannot be inferred. As we are using a convenient sampling strategy to generate the study sample, it affects the generalizability of the results. Also, inaccurate recollection or reporting of the substance used by the participants may subject the data to recall or misclassification bias. And there's also a source of, and also the findings may be subject to social desirability bias, as the respondents from the survey are from the harm reduction supply distribution sites, and they may feel the need to respond by saying that they have been obtaining the harm reduction supplies frequently. So based on the results from our study, we can conclude that 2.5 years after the GSDOA is introduced, there's still a lack of awareness and understanding of the act among the clients of the harm reduction supply distribution sites. And we feel the need that more comprehensive and widespread interventions should be introduced to increase the awareness of the GSDOA among people who are less likely to access the harm reduction services and women. As a part of the GSDOA evaluation project, we aim to initiate more knowledge translation activities to increase the GSDOA awareness among people. And also, I hope you enjoyed our presentation. And also this slide actually shows the different resources available with regards to the GSDOA evaluation project, and some other components of the project will be presented today and tomorrow, so the times are listed. Thank you so much for your time.
Thank you very much. It's really interesting results, and I'm sure folks will want to obtain the PowerPoint, which will be provided via the conference. Are there any questions or comments to Ameti? Okay, so people may have comments and questions as we move forward. So at this point in time, I'm excited to introduce Jessica, who's going to lead a group of folks who will be presenting further information. Apparently, these two groups follow one another. Thank you.
Thank you. I'm just going to share my slides. Give me 1 second. So, hi everyone. We're Mo, Pam, and myself will be presenting today, and we're pleased to be here with you. So we're presenting on take-home naloxone kits, phone ownership, and knowledge of the Good Samaritan Drug Overdose Act among people being released from correctional facilities in British Columbia, Canada. So I'm Jessica Xavier. I'm a research coordinator at the BC Centre for Disease Control, working on the GSDOA evaluation project, which Amiti just presented a component of. And Pam and Mo, I'll let you introduce yourselves.
Hi, my name is Mo Kurczynski, and I'm the Executive Director of Unlocking the Gates Service Society, and I have 28 years experience with addiction and prison, and yeah, I have lived experience.
Hi, my name is Pam Young. I'm the program manager for Unlocking the Gates Services Society, and I have 25 years of lived experience with the justice system, incarceration, and addiction.
And we'll be presenting on behalf of a larger team. So Catherine McLeod, Ali Aqua, Christy Papamihali, and Dr. Martin and Dr. Buxton. So here's the overview that Amity shared as well. So as you can see, what we'll be sharing today is part of a much larger evaluation project where we're looking at GSDOA awareness and attitudes among people who use drugs, police officers, youth, and people being released from correctional facilities. So that's what we'll be sharing with you today. And just to point out, we'll be sharing findings from our component with police officers tomorrow if you're interested in checking that out.
So I'm just going to give a little overview who Unlocking the Gates Service Society is. We are a peer mentor program. So everybody who works for Unlocking the Gates has prison experience and addiction. We mentoring people through 10 provincial correctional centers and 9 federal correctional centers across BC. And we connect with people before they get released and support them with housing, clothing, whatever their needs are. So last year we expanded into men. So now we service all people in prisons across BC, men and women. Yeah. You know, and you see, so in 2015, they started a pilot project of giving take-home kits to people leaving 2 correctional centers, provincial correctional centers in BC. And in 2016, it was offered to the variety of people with who are witnessing and people who are at risk of overdose. So we're going to talk about evaluation of our program.
So during our interview, because they're giving the training at correctional centers, during our interviewing the participants, we noticed that a high number of participants weren't receiving the training. Often they were being released directly from court. And so then we started to provide naloxone kits for the people we were picking up who didn't receive the training within corrections. So we would give them a naloxone kit and a brief training if needed. And then a lot of the people who are coming out don't have the cell phones, and there's such a huge need for cell phones. I mean, the biggest 2 reasons are a cell phone, whether it has service or not, can call 911 in the case of an overdose or emergency. And the second reason is they can download the Lifeguard app, which helps them stay safe while they're using. It's an app that just they log on and before they use, and if they don't check in or log off and you know, shortly after they started using, then alert goes off to ambulance services or medical professionals to send help. So as peers, we have a unique responsibility, or a unique opportunity to connect with people and get maybe a more honest, or they're more comfortable and can relate to us. So we often will get more honest and forthcoming answers about certain questions. But 137 respondents who were being released from a correctional center, or they participated in the UTG program or agreed to a survey. When the data was being collected, 53%, when the data was being collected between January 19th to September 2020. And yeah, sorry. Is there anything you want to add to that, Mo?
No, I guess at the beginning of the study, we're really working with the men or with the women. So part of the study is more towards the women, just because we weren't working with men yet. And also remember, from March 2020, COVID hit, and so we were on major lockdown. So that really played a factor on people not getting kits.
Yeah, and then just to add, so once the peer mentors did those surveys, we used descriptive statistics and bivariate logistic regression to analyze that data.
Yeah, so again, we looked at a variety of different categories, related, custody, where they were, serving their time. And again, also about harm reduction, of your risk, you have a phone, did you receive training? Were you offered a kit? Do you have a kit? Have you heard about the Good Samaritan Act? And would you call 911 if in events of an overdose?
So in these numbers, it says 53% identified as females. And the reason that it's higher is because the first 8 to 9 months that we were doing these interviews, we were specifically working with women. And then during that time, we expanded to work with men. I'm sure if we looked at it now, the men's numbers would be much higher. Of 100, most of the participants were between the ages of 20 to 49 years old. Specifically, female participants 35 years old and males 36 years old, and 39% identified as Indigenous. 37% anticipated homeless or living in a campus homeless shelter upon release, and 30% anticipated they'd be living in a recovery house or treatment center upon release. I mean, often they may have anticipated, but generally we have a really high success rate of getting people into housing, whether that be a shelter or some kind of housing, but yeah.
And that's through the Unlocking the Gates program.
Yes.
Yeah.
And again, there's also only one female prison in BC, and the rest are 9 of them are men. So we definitely, if we did the study now, our men's numbers be way higher.
So here on this slide, so if we go back to our research questions, one of our main research questions was, are people aware of the GSDOA coming out of correctional facilities? And on the left here, you'll see we found that 71% of UTG clients or Unlocking the Gates clients were aware of the GSDOA here in Canada. And as a point of reference, so thinking back on Amiti's presentation, which was at harm reduction client sites in BC with people who use drugs, 54% were aware of the GSDOA. So 71% is pretty high in comparison and in comparison to previous studies, but there is room for improvement there. So like I said, we conducted a bivariate logistic regression to look at factors that may be associated with GSDOA awareness. So here we have the unadjusted odds ratio. And basically what it says is that people who have heard of the GSDOA are roughly 28 times more likely to report that they would call 911 if they saw an overdose compared to people who had not heard of the GSDOA. People who had heard of the GSDOA were about 3.5 times more likely to have received naloxone training during their times in correctional facilities compared to people who had not heard of the GSDOA. People who had heard of the GSDOA were roughly 5 times more likely to have a naloxone kit on them compared to people who had not heard about it. And lastly, people who had heard of the GSDOA were about 5 times more likely to perceive themselves to be at risk of overdose. So another one of our research questions was around, are people receiving naloxone training in correctional facilities? Are they being offered a kit, and do they have a kit upon release? So this graph sort of shows that breakdown. We stratified by participants at risk of overdose, and this is self-perceived risk, and participants not at risk of overdose. So we were obviously, for obvious reasons, interested in participants at risk of overdose. And here, I'll just point out that on the x-axis, this is the number of participants. The pink bar represents people who had a kit, the light green bar, people who were offered a kit, and the dark green bar, people who received training during their time in correctional facilities. And what we saw was that, so overall 46% perceived themselves to be at risk of overdose. 71% of those who were at risk of overdose received naloxone training. There's a bit of a drop off, so 68% of those who are at risk of overdose were offered a kit, so a little bit lower than having received training, and then 68% had a kit upon release.
And again, one of the biggest percentages is people not having access to a cell phone, and of course, for many reasons, most of them who get arrested don't have their belongings when they end up in corrections. And for us, it's a very big barrier of being able to find cell phones for people who are being released. If I had my choice, I'd like to see everybody have a cell phone to be able to have that extra safety with the overdose crisis here in BC. But yeah, we're working on it, writing grants. I think having cell phones would be a big barrier, less barrier for people who are at risk of overdosing. And because we're more likely to report calling 911, and I think it has a lot to do with the Good Samaritan Act, that they know if they, if the police officer or an ambulance show up and they have drugs on them, they're not going to get charged. And high-risk people reported being incarcerated for life. And the people who actually ended up with kits were actually incarcerated longer, and usually the ones that are sentenced, especially in the last year with COVID. And mass releasing people from prison, people are not getting training. So we now make sure unlocking the gates that everybody has a kit. Doesn't matter if you're going to treatment or where you're going. We just want to make sure that everybody has a kit who we come in contact with.
So when we pick up individuals, I spoke a little bit about this, but we reinforce the Good Samaritan Drug Overdose Act. They hear about it in prison. Well, they do that if they do the training, but we also discuss it with them and provide them with a wallet card to increase the likelihood of calls to first responders in the event of overdose. The kits, if they do not have a kit in corrections, as I mentioned before, we will provide them with a kit and do a brief training on how to use the kit. Majority of the people do know how to use the kits already, but we do provide training if needed. And the mobile phones, again, it's the two biggest barriers with the mobile phones. I mean, there's not a lot of mobile phones available. There are some programs and organizations that are giving cell phones out, but is to be able to call 911 in emergency and to be able to download the Lifeguard app. We usually connect with people. We connect with people through it's self-referrals through to become a participant of UTG, and so we're solely connected through self-referrals. So data collection by trusted peer mentors is likely to increase participants' feelings of comfort and thus reliability, so we can connect with people on a deeper level of understanding of what they're going through, because we've all been there. Our whole team's been there themselves. And then this lists some limitations, like participants self-selected to meet a mentor and complete a survey. Findings might not be representative of a person released from provincial BC corrections, and small size, limited strength of possible correlations for subgroups. And self-reported data may be constrained, and as like I spoke before, is everyone is self-referred to unlocking the gates. So we're not looking at the whole entire all the releases from correctional centers. We're just looking at the people that self-referred to unlocking the gates.
So with that brings us to the end of our presentation. I think it got away from me, but I don't know how we're doing for time. Do we have time for questions?
Yeah, we have a few minutes. Are there any questions for Jessica's panel or any of the other panels at this point? Thank you. Great presentation from Jane Buxton. Anyone else? Any comments, any questions that anyone might have?
Yeah, there's one here about somebody else who's similarly in the same situation. Yeah, is the justice system being involved? No, it's something, I think, the main reason ours is lack of housing, a lack of places for people to go. And, the number of people that get released every day be quite the, job to making sure everybody has cell phones. But it definitely would be something I'd like to see everybody being released having a cell phone, even if it was just access to 911. And it's something we're really working on, as the overdose crisis is something that's really dear to our organization. And we've been impacted, by family members who have, died, and, hundreds of women and people we know are no longer here. So, yeah.
Okay. There was someone who wondered how the ability to text 911 might impact the population.
Again, you'd have to have a cell phone to be able to text 911. So again, that's the lack of cell phones. as well.
And someone asked how the lifeguard app helps impact on the prevention of overdose deaths. And I hope I'm not repeating.
Pam, you want to talk about that one?
Yeah, so the lifeguard app, once you log on to the app, you have a certain time, like if you log on before the person is going to use, and then if you haven't checked in or after you've used over a certain period of time and you don't register on the app for a certain amount of time, then they will alert emergency services to come to you and assuming that you've had an experience an overdose. So that'll send like first responders, firefighters, ambulance directly to you.
Okay.
But again, you have to have a cell phone. So there's the other barriers, but it's an amazing program and it's saved many people's lives by using the lifeguard app.
Okay, thank you. All right. Any other comments or questions at this point? We have 2 new messages. Maybe over time, drones could be considered for delivering kits to harder to reach areas. It's a great idea.
Yeah, that's a good point. Especially in Canada, we have a lot of more rural areas. So it's an interesting
Absolutely.
thought.
Yeah, for sure. Anyone else? Well, I think the presentation of all 3 panels has really provided us with an interesting outlook in how to move forward in relation to the work that we're all doing around substance use disorder. And so I hope you all will partner somehow together, network, talk about how we can overall globally impact on this important topic. You all are doing amazing work. We applaud you. Thank you very much. Take care.
Thank you.
Thank you.
Thank you.
All right.
Thank you. Bye.